Hello everyone, I'm Dr. Akash. Welcome to my channel. In Mrcs SEO Shorts, we'll be covering a very important topic today, that is shock. How do we define shock? Shock is defined as a state of systemic hypoperfusion of organs or tissue due to decreased cardiac output or decreased circulatory blood volume. In simpler terms, the overall blood supply to different tissue and organs is decreased. What to expect now? This leads to cellular and tissue hypoxia. Whenever there is decreased blood supply, it will lead to decrease in the oxygen in the tissue. It can occur either due to decreased oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of the whole process. So this basically leads to an anaerobic metabolism in the cells and tissues, which will result in increased in lactate, which is the byproduct of anaerobic metabolism. Let's move on to the classification or types of shock. As you know, we classify shock into hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. In distributive shock, there are three: neurogenic, anaphylactic, and septic shock. Just to make a mnemonic of the distributive shock, you can remember as NAS, NAS, neurogenic, anaphylactic, and septic. Let's move ahead and let's understand different parameters. So before we move ahead, I just want you to be familiar with a simpler equation. You can note it for your future references as well. So what basically is blood pressure? Blood pressure is the byproduct of cardiac output and thus systemic vascular resistance. So if we make a simple equation out of it, so blood pressure or the mean arterial pressure is the byproduct of cardiac output and systemic vascular resistance. So let's make it even simpler. What is cardiac output? Cardiac output is stroke volume into heart rate. So basically this makes our equation into blood pressure is equal to stroke volume into heart rate into total peripheral resistance. So just to make you familiar with the short names, the MAP is the mean arterial pressure or the blood pressure, HR is the heart rate, CO is cardiac output, SVR is systemic vascular resistance, PCWP is the pulmonary capillary wedge pressure. So let's start with hypovolemic shock. So how to identify hypovolemic shock in the question itself? The striking points that you should note is that there will be a history of massive blood or fluid loss, or there will be a history of burn or vomiting or anything as such. So what will happen then? It will lead to shock, right? And by definition, we define shock as the systolic blood pressure less than 90 or the overall blood pressure less than 90 by 60. So this leads to decrease in the MAP or the mean arterial pressure. From the equation that we have discussed, we know that the blood pressure is the byproduct of cardiac output and systemic vascular resistance. What happens in hypovolemic shock? As the name suggests, it is called hypovolemia. So the overall circulating blood is decreased. So what will happen if the overall circulating blood is decreased? It will lead to decrease in the cardiac output because there is less blood, so there will be less output. So then you can see the cardiac output is low. As the blood pressure is byproduct of cardiac output and the systemic vascular resistance, and in simpler equation it is the stroke volume into heart rate into total peripheral resistance. So breaking the cardiac output, is that the cardiac output is stroke volume into heart rate. So now there is less blood in the body, so this leads to decrease in the stroke volume. To compensate for the stroke volume, the body will try to increase the heart rate. Thus the heart rate is high in hypovolemic shock, and the pulmonary capillary wedge pressure, it can be normal, it can be sometimes increased or decreased. Now moving to the next one, it is the cardiogenic shock. So as we have discussed already, it is a type of shock itself, so the mean arterial pressure is less. But what is the striking point here that you will notice in the question? The striking point is that there will be a history of cardiac disease. Sometimes it's given ischemic heart disease, or sometimes some kind of arrhythmia or any valvular heart disease. So what happens is that, as the name suggests, it's the cardiogenic shock. The genesis is from the heart itself. So due to a disease of the heart itself, the heart is not able to pump the blood. Thus there is decrease in the cardiac output, because your pump, that is the heart, that is not able to pump the blood itself, so the cardiac output is less. And as we have discussed it in the hypovolemic shock section, when the cardiac output is less, cardiac output is the byproduct of stroke volume into heart rate. So when the stroke volume is less, due to there is less pumping capacity of the heart itself, the body will try to compensate it by increasing the heart rate. Yes. And what is the main thing that you'll notice whenever you are finding a case of cardiogenic shock in your MCQ? There will almost always be increased in the pulmonary capillary wedge pressure. Now you'll ask why. Okay, let's understand it. When the heart is not able to pump the blood out, what will happen? From the lungs, from the pulmonary vein, the blood comes to the heart, right? And this blood is not being pumped out of the heart. So what will happen? There will be increased amount of blood pooling in the pulmonary vein and the pulmonary vascular system itself, that will lead to increase in the pulmonary capillary wedge pressure. And what happens to the systemic vascular resistance? It's the same as we have discussed. Whenever the blood pressure is low, the stroke volume is low. To maintain the blood pressure, the other parameters rise. Like the first one we discussed, it's the heart rate. Yes. And the second one now, it is the systemic vascular resistance. Then we move to the next one, that is the obstructive shock. So many get confused between the cardiogenic shock and the obstructive shock, because all the parameters are almost same. But as I have discussed before, in cardiogenic shock there will always be increased pulmonary capillary wedge pressure. So that is the striking point. But what to expect in a question when it will be obstructive shock? So the striking points that we need to notice is that there will be some extra cardiac pathology. Mainly there are two types of questions. One is massive pulmonary embolism, another is tension pneumothorax. Rest others are same as before, but as the cause is not cardiac one, so the pulmonary capillary wedge pressure doesn't increase much. Now another important one, neurogenic shock. So now, as we are discussing previously 3 types of shock, now you'll ask why this is important. This has its own significance. Let's understand this. So like in the previous shock, there will be decrease in the mean arterial pressure because it's a shock. But what's the cause in neurogenic shock? So the striking points will be, there will be a history of spinal injury, there will be a cord transection. So what basically happens is that when there is a trauma at the thoracic level, There are some cardiac accelerator fibers that come to your heart, and as you have studied in physiology, your heart is supplied by two types of nerves, sympathetic and parasympathetic. So what happens in a normal heart? In normal heart, the parasympathetic or the vagus nerve supply is always dominant in comparison to the sympathetic one. Yes. Why this line is important? Let's understand. So whenever there is decrease in the blood pressure, the body will try to cope it because now the cardiac output is low. Why the cardiac output is low? Because there is decreased stroke volume, and whenever there is a decrease in the blood pressure, the body will try to cope it by increasing the heart rate and increasing the systemic vascular resistance. But unfortunately, in this case, due to spinal trauma, the cardiac accelerator fibers or the sympathetic fibers, mainly coming from the T1 to T6, are lost. Thus, the heart rate will not be increased to compensate for the blood pressure itself. That's why the striking point that you should notice in case of neurogenic shock, there will be classical decrease in the heart rate, which is not seen in any other type of shock. Then you'll ask, okay, then why the systemic vascular resistance is decreased? Okay, let's understand. So the sympathetic tone is also required to maintain the tone in the peripheral blood vasculature as well. So when there is decreased in the sympathetic tone, the blood vessels which try to compensate for the cardiac output, that is not seen as well. Thus the systemic vascular resistance is also decreased, and you will classically see there will be warm and flushed dry skin in case of neurogenic shock. Now comes a special one, and as I have told you before that this anaphylactic shock, neurogenic shock and the septic shock will come under a specific category, that is the distributive shock, because in almost every one of them the systemic vascular resistance is decreased. Thus there will be increased pooling of blood in the peripheries. What happens in the anaphylactic shock? There will be history of exposure to allergen, drug or substance. So this is a type 1 hypersensitivity reaction. Which cell is responsible for anaphylactic shock? Yes, it is the mast cell. And which mediator is important in case of anaphylactic shock? Yes, it is mainly the histamine and other vasodilators. So when there occurs vasodilatation due to all these mediators, the systemic vascular resistance is decreased, and all the parameters go same with other types of shock. So you have to see about the history of exposure to an allergen, drug or substance in the question itself. And what's the treatment for anaphylactic shock? Please let me know in the comment section. So like other types of distributive shock, the feature is same in case of septic shock as well. The mean arterial pressure is decreased, the heart rate is increased, the cardiac output is increased. Why? Because of some hyperdynamic circulation. Why it happens? Because in septic shock, the patient is in a state of sepsis. There is active infection going in the blood. So like as any patient who has fever due to some inflammatory mediators, there occurs some tachycardia throughout this phase. So this leads to increase in the cardiac output. But as other distributive shock, the systemic vascular resistance is decreased. Why? Because of all the pathogen, all the endogenous and exogenous inflammatory mediators. So what's the striking points that we have to see in case of septic shock? There will be a history of infection, there will be signs of systemic toxic features, and mostly they will give you a positive blood culture report. So just to cut the long story short, how we can treat shock? So let's again remember the equation. Blood pressure is equal to cardiac output into systemic vascular resistance. Cardiac output is stroke volume into heart rate. So blood pressure is equal to stroke volume into heart rate into systemic vascular resistance. How we can increase the stroke volume? By increasing the circulatory blood volume. How we can do that? We can do that by giving some IV fluids or blood. How we can increase the heart rate? By increasing the heart rate, we can give some inotropic agent. How we can increase the systemic vascular resistance? By giving some vasopressors. And as I have asked, please let me know in the comment section what's the treatment for anaphylactic shock. If you have any doubt, please write me in the comment section, and if you want any video in particular, please let me know. Thank you. Hope you like it.